Please allow me to introduce Mariya Prilutskaya. Mariya is a research assistant at Semey Medical University in Pavlodar, Kazakhstan. She has graduated from Astana Medical University in 2008. She has worked as a psychiatrist for 10 years and is interested in drug research. And in the last 7 years, she has focused on the problems of novel psychoactive substances in clinical practice of Kazakhstani doctors. With the research team of the University of Hertfordshire, led by Ornella Karatza, Mariya studies the epidemiological and clinical aspects of synthetic cannabinoids and cathinones in Kazakhstan. She participated in development of national clinical standards for management of addictions caused by novel psychoactive substances, and her research activities were supported by CUT-UP project and UNODC. Mariya will talk about the usage of NPS in the Republic of Kazakhstan. Please, Mariya, the floor is yours.
Thank you so much, Estelle. Thank you for everybody. It's my pleasure to be here as a part of this honorable panel of experts. Let me introduce you some of our data, of our local data about the situation in my country, in Kazakhstan. Kazakhstan is a country in Central Asian region that predominantly had facing the problem of opioid and cannabis traffic over the 90s and 2000s. The geographical position of Kazakhstan has historically enabled the continuous trafficking of opioids through the country. In addition, Kazakhstan has been home to large historical cannabis cultivation zone. The mid-90s saw the establishment of the main heroin trafficking route from Afghanistan, called the Northern Trafficking Route or Silk Road. This road goes through the most famous territories of Tajikistan, Kyrgyzstan, to the Russian Federation and Eastern Europe. And in addition to that, in 2000, two newly emerged truck trafficking routes became popular in the territory of my country. So the Southern and the Caspian Road. In 2019, the estimated number of people who inject drugs amounted to up to 95,000 people. And the hospital-based incidence of opioid abuse decreased from 3.0 to 2.4 per 100,000 population in 2018 and 2019 respectively. The HIV prevalence in people who inject drugs was 7.9 in 2019. Unfortunately, methadone program is underrepresented in Kazakhstan, only 0.3% cover of injection drug users. And in 2009, first media report in this context, followed by the police report in 2010, indicated the NPS onset on the illegal local markets. And by 2016, 58 NPS had been identified in Central Asia, when 2/3 of these drugs were traced in Kazakhstan. A rising number of online vendors within social networks and on the dark web reflected the growth of NPS supply capacity. And according to the Drug Start study, the total revenue of Hydra, notoriously known drug market for Russian language territories from Kazakhstan transactions comprised $3 million in 2019 compared to $990,000 in 2018. Methadone and alpha PVP substantially dominated on the market. Our country has a stepwise experience in combating NPS challenges. At the beginning of this NPS story, anti-NPS regulation was developed on the level of consumer safety. regulation that wasn't actually effective and followed by the individual listing system on the low level. But the exponential growth of NPS markets required new legislative anti-NPS initiatives in a form of analog-based anti-NPS system in 2014. In 3 years after first clinical standards were introduced for the management of patients with NPS addiction, first in Central Asian region actually. Finally, in 2018, the combined legislative approach was introduced with a generic system, a rapid banning procedure, and the list of harmful NPS formulas. From a public health perspective, the proportion of patients suffered from NPS abuse has increased at drug addiction clinics over a 3-year period, from about 4% in 2016 to up to 10% in 2019. Remarkably, not all regions of Kazakhstan have equal distribution of NPS patients. For example, northern, northeastern, southeastern territories, regions which border immense markets of China and Russia had considerably higher rates of clinical admissions due to NPS use. As for 2017, we register among our patients various ways of drug administration for synthetic cathinone, especially where injections dramatically prevailed, high-risk injection. Another striking feature of our treatment-seeking NPS users was a combination of NPS with other substances. Synthetic cathinones were combined with classical opioids, mostly synthetic cannabinoids with natural cannabis. To characterize our current activities for NPS studies in the country, we could use the term bricolage, considering our attempts to glean information wherever we are able to. The local study undertaken in 2016 and 2017 in the group of more than 500 treatment-seeking NPS users revealed some finding on psychosis and risk injection. Every second NPS user experiences psychosis and only a fifth of those received medical care. Combination of 2 and more NPS group tripled the risk of psychosis. NPS injection were associated with a twofold risk of utilizing common vials or syringes, and risky NPS injection were more relevant to opioid users. The national study with hospital-based sample of more than 300 NPS patients helps shed light on the profile of those who suffered from opioid plus synthetic stimulants addiction. In the given sample, they accounted for a third of all these cases. It turned out NPS users who inject opioids were older, more likely to live in northern regions of Kazakhstan, more likely to be of Russian ethnicity, often undereducated, use stimulant less often per day and per week, but in a higher doses, and practice parental routes of stimulant administration 2.5 times as often as their non-opioid counterparts. Here you could see a photo taken in northern region city, which faces the highest prevalence. Actually, it faced the highest prevalence of heroin stimulant co-use in 2017. And the photo depicts a typical place of heroin intake where walls are covered with NPS ad graffiti. And in this context, we could see that the prevalence of HIV prevalence is unequal between different strata, between different drug users, where the lower percentage, the prevalence of HIV related to stimulant users who use these drugs by snorting, and for example, 7.9%. That is the prevalence of officially acknowledged prevalence among injection drug users. I think it's mostly related to opioids users. And you can see that a third of injection users, injectors who inject opioid plus stimulants had the problem with HIV status. And another study supported by CDC with 73 HIV plus positive cases and 111 HIV negative controls examined factors associated with the risk of parental infection in the context of NPS emergence. And the study was carried out in that region, which photographs you could see earlier. The study in 2017, and among the factors there were a range of those related to synthetic stimulants used in combination with opioids. And in general, in final model, heroin injection with basalt use. So it's basalt, it's a street name for NPS stimulants in Kazakhstan. So basalt use, shared syringe, younger age, and invasive medical procedures were the factors associated with HIV outbursts in that region. With the support of CADAP, the project epidemiological portrait of NPS in Kazakhstan, a pilot investigative research was carried out in 2019, and the data were obtained with a survey conducted in 70 major cities, represented all the regions. The target population was young people aged 18 to 34. And just about a half of these respondents were aware of NPS, knowing them under the various street names, spices for synthetic cannabinoids mostly, and scores for synthetic catechins were more prevalent. A third reported on at least one person with NPS experience in their immediate circle. The NPS using respondents were about 8 times more likely to have NPS using friends than their non-NPS counterparts. And within the survey, about 11% of the respondents reported having used any illicit drug except NPS, and 6.3 used NPS at least once in their lifetime. Namely more than 9% of men and more than 3% of women have ever tried NPS. The type of use NPS differed between the regions. The synthetic cannabinoids were more prevalent in northern regions, while synthetic stimulants, catechins, dominated in the capital, Nur-Sultan. So the most prevalent were synthetic cannabinoids and synthetic catechins in the age group of 25-29. The absolute majority of NPS using respondents bought the drug through internet with online vendors, social networks, drug forums, and dark web markets. The price of NPS was higher than that of marijuana, but substantially lower comparing to controlled stimulants like amphetamines, cocaine. A wide range of clinical symptoms were described in this survey by the respondents, including neurological conditions, retaining for 24 hours after NPS intake after this episode. A third of respondents experienced psychomotor agitation to some extent. And in the form of final question of the survey, we ask the users to estimate the relevance of different motives for NPS use among Kazakhstan population. And noticeably, NPS using responders more often assessed price, availability, and pseudo-legality as an important motives for NPS use. In parallel, they pointed out recreational and empatogenic effect as casual factor as NPS use. So triangulating the mentioned data, we concluded that the trend of polysubstance use with opioid and stimulants combination now is on the rise, currently is on the rise in our country. Introduced as substitution for poor opioids on illegal markets, stimulants are now challenging the dominance of opioids. Combination of opioids and stimulants increase the risk of transmitting parental infections. The situation is aggravated by the stigma attached to opioid users switching to stimulants. Lack of awareness and misconceptions about stimulants use, especially HIV transmission risk, reduce the quality of preventing program for those who go beyond the scope of exclusive opioid use. So the main finding regarding NPS use in youth includes the following observation. the regional disparity in NPS prevalence, higher proportion of men, predominance of synthetic cannabinoids with online channels of drug distribution, higher likelihood of NPS use in association with traditional drug in younger age group, numerous clinical symptoms due to NPS intoxication, significant role of legality, availability, and price for the motivation of NPS use. So thank you for your attention.
Thanks so much, Mariya. Very interesting presentation, and it already stimulated quite a few questions while you were talking. I'll just start addressing first the questions, and maybe we can then jump on into a more broad discussion. The first one is from Ingo Iya Michels. He asks that you mentioned clinical standards from 2017. Can you share these standards with us? And are you aware of any good clinical guidelines used in the UK, for example, called Neptune guidelines?
Yes, thank you for the question. Yes, we have these standards launched in 2017. That time something like played a role of something, the first step in these initiatives to develop new and or to acknowledge a role or a harms of NPS. I don't think we have there a lot of dramatical change compared to traditional drug addiction treatment strategies. Of course, it includes a three-step approach that we already have in Kazakhstan. It's a medical correction of a withdrawal symptom. The second step is psychotherapy program, and after that is social rehabilitation that are only advised to be longer, considering the higher rate of relapse in this addiction with this patients. We are planning to update these recommendations, this clinical, not as a guidelines, but it's mostly like clinical document, a short document. So it's minimal standards for doctors to deal with this diagnosis, because this diagnosis is absolutely new for our medical staff. So yes, I know about this Neptune initiatives. Are very, I think, invaluable for us, because it's the first in the field, and they have a lot of good recommendation. Unfortunately, not all of them could be feasible for our situation in Kazakhstan, because outpatient program is a weak point for Kazakhstan. We could only propose a good option in our hospital program, but unfortunately not so strong considering outpatient programs. So yeah, we should considering this limitation. And unfortunately, these documents only on the Russian and Kazakh languages. But anyway, but still I could post in chat the link for official site.
Wonderful. I think a couple of people are interested in links. Eliza asked, "Dear Mariya, this is a great and interesting presentation. Thanks for sharing it. Could you please share a report of 2019 survey if it's developed?"
Okay, yeah, this survey, actually this project had two parts. One of them is a clinical part, and the second one is a survey. So clinical part has been already published in English, so but in local journal and I could post a link for our results considering hospital-based sample. What's about as for youth survey, now it's in the process of publication, of preparation, and now we actually had just started preparation for the second round, so second wave of this youth survey. And we are planning to involve 3,000 youth across the country. It will be interesting to compare the data. It's a dynamic, because the first wave was before the launching our new NPS legislation, and the second wave is after, and we could compare and could consider whether any impacts were introduced into the field.
Thanks so much, Mariya. We have a couple more links here from Ingo Miches and a question from Daniela Forlano if it's available in English. I guess that's what you mentioned, that was published in English, but in a local journal, and you will share a link with us. Ingo Miches has also written that we will discuss a Russian and Mandarin translations of the Neptune guidelines and the SOLID project so that they can be adapted and used in Central Asia and China. I was also quite actually struck when you said that every second user of NPS experiences psychosis and only 1 in 5 gets treatment. Is this a specific number for Kazakhstan? And I was wondering, how do these cases get registered? Is there a certain direct contact between, for example, I don't know, outreach social workers or directly with the clinical professionals? Yeah, if you could elaborate on this.
Yeah, it's. I think it's a real big problem for us, a dramatic problem, because we shed a light on this data by survey, only by asking them by purpose whether you have your psychosis episodes, and most of them experience it. That said about the risk harm use of this, and of course it's underrepresented. And the drama is that our doctors not always ask about these symptoms. They did not describe this in medical documentation. It could be toxicologist or drug addiction psychiatrist or psychiatrist by definition who dealt only with psychosis. Yes, it's so difficult to extract, to glean this information. So I think that this preliminary data is actually remarkable, and we have to adjust our system because they need help, they need medical support, and very often we as doctors don't understand who exactly is responsible for this treatment, psychiatrist or drug addiction psychiatrist.
Thanks very much. Are there any other questions or comments? We have a bit of time this time because we're now heading into a bigger break. So feel free to kick off any discussions.
There's a remark from Ingo in the chat.
I read already this one. The translations, right? The Russian Mandarin translations.
Yeah.
Mm-hmm. Just got a question on prevention, because we will discuss this later on as well. And especially when I work in Central Asia, I found that prevention work is always, not always, but very often, seen to do sport events, for example, or mass media interventions like drug-free Astana or something like this. Do you think that this is really working for these users of NPS?
It's a for me question. Yeah, of course. I don't think it's work at on 100%, and especially with NPS. First of all, we have to develop more sophisticated programs, more elaborated programs for prevention for different strata of for different group of our patients. For younger experimental users, it should be one package of intervention. And of course, I think this mass media prevention is up to no more than 10% of efficiency and efficacy of these strategies, preventive strategies. Of course, I think it should be developed, and but by now we have inefficient procedure not only related to NPS but also for any drugs. So, and especially in the context of NPS, the situation is exaggerated mostly. And we have recently we had one project with United States, and I hope, thank God, they will be published soon in English for Kazakhstan, where we discuss with our patients, users, NPS users about preventive efficiency of prevention program, and they said no, we don't know anything about NPS. For example, NGOs, they really need information, they really need trainings, they really need support for online outreach, for field outreach with NPS, and it's a really challenge for us now.
Another question, in 2019, we organized within the CADA project a training in Almaty with representatives of all Central Asian countries on opiate substitution treatment. And in this meeting, it was also discussed there should be some reform steps in Kazakhstan, because the expert there, for example, the narcologist and the psychiatrist like Nikolai Begay, they know about the problems if persons are not allowed to go to the OST treatment if they're using other substances. Do you have an idea how to change this regulation?
So, yeah, it's for me, it's difficult to discuss about this, because methadone programs, the substitution program, it's something beyond my scope of my background, because not everybody are trained on methadone programs in Kazakhstan, not all doctors, only something up to 200 doctors have the expertise in the field. But I ask clients, I discussed these methadone programs with them, and they mentioned that whenever they indicate that they use NPS, it's something like additional barriers for them to be accepted for this program. And I think it's critical for us. The second issue is a laboratory identification, detection of this NPS use, because when we identify NPS or any other drugs, we could build up rehabilitation or CBT therapy session based on the result, yes, based on their sobriety regime, but we don't have. So I think now in this current project, we identified that something up to only 6 regions have this express strip toolkits, where key to strip and MDPV, they have this lab. Unfortunately, we don't have special laboratory equipment for identification with mass spectrum. So it's difficult.
Thank you both for having this interesting discussion.